right, so we're going to go through these questions. This will take quite a bit of time in and of itself, but I think it's helpful because a lot of this material stuff that we've covered, and I think part of learning the module is like memorizing the material, understanding the signs and symptoms, what are the tests that we order, and all that good stuff. But then it takes it to another level when you have to actually apply all that knowledge. And so I like doing questions. I do a lot of questions even as an instructor because I feel like that's the best way to know where I stand, how much I know, what are my gaps in my knowledge. So this test I came up with while I was coming up, when I was like fishing for things for your test. And I was trying to, like, as I was going through, I would see a question. I'm like, ooh, that's good. Ooh, that's good. And so that's how I kind of made this little list of questions. So if y'all are cool with it, let's get started. Let's start dissecting these questions. So number one, right off the bat, we see a 50-year-old. And even when I just see the age, I'm already starting to kind of think, and he has a 90-pack year of smoking. So that's not good. Okay. Shortness of breath is the chief complaint, as well as worsening cough. And then they start mentioning about his cough, that he's had it daily for the past 10 years. And now he has some blood tinged. So maybe a component of COPD. Now we have some hemoptysis. So not good. He had been trying to lose weight. Proud that he's now lost 100 pounds in a year without exercise. He might think that's a good thing, but as a clinician, I don't think that's so good, right? That even though he tried to losing 100 pounds in a year without exercise is worrisome. Okay. No fever, no chills, no vomiting, diarrhea. He has gotten his vaccinations, colonoscopy. He takes some medications. Vital signs are normal. On chest X-ray, we have a 5-centimeter irregularly shaped mass in the right upper lobe. If I just had those two characteristics to go on, as far as a mass, are those indicative of good or not good? Yeah, not good, right? So anything more than 3 centimeters is worrisome. That's pretty big. Centimeters are big. Yeah, keep an eye out in vignettes for millimeters versus centimeters. Millimeters is a lot smaller than centimeters, okay? Remember, when we find an irregular mass on there, the first thing we want to do is go looking for previous x-rays, which they did. They found an x-ray from 5 years ago, shows that it has grown significantly in the past 5 years. So then we went ahead to order the CT, and it reveals a mass from the parietal pleura without extension into soft tissues. And this is important. The location of the lesion is important. So parietal pleura, that means, is it more central or more peripheral? Right. Peripheral is close to the pleura, the parietal pleura, pared, right? The chest wall. So it's more peripheral. And so now, if we had to make a guess what kind of cancer this is, it could possibly be one of the more peripheral ones, like adenocarcinoma. I'm not sure what it is, and that's not what it's asking. What it's asking is, how would we approach a lesion that we think is a cancer that is located on the periphery? And so, is it something we're like, nah, don't worry about it, we'll just get a CT again another 3 months? No, right? We need to figure out what this is so we can try to start treatment. Does everybody know what a bronchoscopy is? So a bronch in the airways, oscopy is a camera. So they basically go in with a camera into your lungs, and that mainly will access the more proximal airways, so the bigger airways. You cannot get all the way to the periphery with a bronchoscopy, which is why that's incorrect. A video-assisted thoracoscopic surgery, a VATS procedure, is where they go in with a camera into the lungs and they're into the chest cavity, and they try and figure out where the lesion is and how to biopsy it. That would be a good option as like a second option. But for this one, the best thing to do is a CT guided biopsy. And that is because we can get it from the outside. So we're going through the chest wall because it's peripheral, and we're going to use CT to help guide us to take a piece of it. Okay. So that was a little harder question. I'm not sure that I would get that specific on a cancer case, but I know we had some questions in class about, well, what do we do next? What's the next step? And so I felt like these 3 questions, the first 3, helped me when I was reading them to say, oh, that's what I'm looking for in a vignette to tell me I need to do this versus that. So that's the first one. When we read the second one, it's a pretty similar. We have the same 5 answer choices. Okay, this one's a 67-year-old, and he also has a pretty large smoking pack history, shortness of breath, and a cough, and he's having some night sweats, fever, weight loss. He's lost quite a bit of weight. Chest X-ray reveals a 3-centimeter irregularly shaped mass in the right upper lobe. He has a CT, and it's originating from the right main stem bronchus. So it's pretty close. We were talking about main stem bronchus, so that's pretty central located, right? You also have some lymph nodes. So on this one, is this one more central or more peripheral? Central, right? So we said that if a mass is central, that we should be able to reach it with the camera. And so on this one, the better next step, instead of going from the outside where we won't be able to reach it, is to go down through the bronchus itself and reach it via bronchoscopy. Okay. Now, third off, another same 5 answer choices. Now we have a young person. He does not have a smoking history. He comes in with shortness of breath, worsening cough. And he's also having sweats and fever, weight loss. I'm not sure exactly what it is. There is a family history of leukemia. He appears cachectic, which is really, really wasted thin. He has a 3-centimeter irregular shaped mass in the middle lobe. So not sure exactly where in the middle lobe, but it's in the right middle lobe with enlarged lymph nodes on the abdominal side near the liver. No effusion. And he has no cutaneous manifestation, so nothing on the skin that you can get to. So basically, this is kind of in no man's land. So it's not really peripheral, it's not really central. And so this would be a kind of a difficult mass to reach by either a CT guided biopsy or bronchoscopy. So in this case, the recommendation is to do VATS. And like I said, VATS is where you go in kind of with a camera in the pleural cavity, and that one helps you kind of navigate into uncharted territory where it's difficult to reach from one side or the other. I don't, like I said, these are really hard questions, but I wanted us to see 3 different cases back to back to try to see if we could pick up on clues in the vignette that would lead us to which would be the correct next step. So hopefully I didn't confuse you more, but I wanted to start with those 3. Now let's do number 4. So we have a 66-year-old and obtundation. What does that mean? Obtunded. You're almost unresponsive. Like obtunded is like, I think of like when, this is probably a bad example, but have you ever seen like a cartoon where they like smack someone in the head and they have the little canaries like floating around their head and they're just kind of like out of it? You have to kind of like shake them to get them to come back to attention. That's what I think of for obtunded. She was seen yesterday acting a bit confused. Okay. She's a smoker with a 56-pack year history. Sorry. Let's see, 56-pack year, so that's not anything to bat your eyes. That's pretty big, pretty good long history. Okay, so let's see. She's been intubated to protect her airway because obtunded patients can aspirate. She has a low serum sodium. And she has a diagnosis of SIADH. Now, keep going. Chest sodium improves. A lung mass is found. So now we have a lung mass plus SIADH. And there's only one lung cancer that has SIADH related to it. Which one is that? It's a paraneoplastic syndrome. Very good. Yeah, small cell. Good job. So do you see how they would play it out in a vignette? like I got kind of scared because I was reading. I'm like, crap, am I gonna have to figure out what I need to do with this patient? She's intubated, but really, of all these words that are here, it's basically saying what does most likely patient have when they have a lung mass and a SIADH. So not so bad. Okay. Keep going. Now we're talking about a PD patient, 8 months old. So if we were like betting statistic wise, epidemiologically speaking, an 8-month-old, we talked about several diseases in pediatrics, and we had these concrete kind of age recommendations when they typically get it. So the one that you see mostly in that months range is usually bronchiolitis. Okay. But it could be a bunch of other things. I'm not going to assume, but I'm already starting to think like what would be common? What would be common? So I keep reading. She's had fever, runny nose, cough for 3 days. And then she's also having trouble feeding. So if you're not a parent, basically when kiddos are like drinking a bottle or whatever, they breathe through their nose, and when they're drinking a bottle, and so they're having trouble feeding because they can't breathe through their nose. It's so clogged up that they're like trying to like gasp for air in between trying to eat. They also have low grade temp, moderate respiratory distress, nasal flaring, expiratory wheezing, and the x-ray is going to show just a little bit of hyperinflation and peribronchial thickening, which is like inflammation in kind of the smaller airways. So when we see this picture, what does it look like to you? So in this case, did y'all think, to me, what RSV looks like when I read it in a vignette is I read it as kind of like bad asthma plus infection, because it's affecting those same smaller airways. So you get a lot of wheezing, respiratory distress, which is different in each age category. Little kids are going to have nasal flaring and trouble breathing. But this one, with the history, I'm thinking bronchiolitis. And so the most common cause of bronchiolitis that we know is RSV. And that's how I came to that conclusion there. Right. Next up, excuse me, I'm about to sneeze. But now I can't. Okay, 4-month-old male. Again, 4 months. We haven't talked about too much in 4 months, but let's keep thinking. Gasping for air, turning purple. Oh, that's bad. RSV reminds me of asthma, but infectious asthma. I know that's not correct, but it makes me think of infectious asthma. So this is a 4-month-old, again, same age range as like the RSV stuff. And this one is gasping for air, turning purple during coughing fits. So that, to me, when I'm reading that, like that's not as common for bronchiolitis. Like if you're turning purple for bronchiolitis, like that's not cool. I've never seen that. And they also have some runny nose and fever, so we're thinking infectious. And really, really big here, not immunized. They're not just telling you that just to, oh, by the way, they're not immunized. No, it's like very important for this case. At low grade temp, they're satting okay. They're not doing bad when they're not having the paroxysms, the coughing paroxysms. Basically a normal exam, intermittent cough. So can you see the difference in this presentation? Like they are clearly pointing you towards pertussis for this case. Do you see the difference? Do you see the difference in presentation between the cough, runny nose, but more shortness of breath, wheezing, and this one is paroxysmal problems. The problems with breathing and the cyanosis come with the cough. Okay, you see that? So in this case, we have to be able to read this vignette and know, I think it's pertussis. And with pertussis, we know that the treatment of choice is a macrolide. But if it was no biggie, like not having these cyanotic fits, I could probably just prescribe Zithromax. But I mean, turning purple, like you don't want to just send them home. You need to make sure that they're not going to, keel over on you. So they need to be hospitalized for admission, at least initially, till they get the medication on board. Plus, the Zithromax, I apologize for the dog. The Zithromax is only this option. So that's what makes the most sense. Y'all got that? 17-year-old woman. She's having wheezing, coughing, shortness of breath during track practice. So they didn't just say track practice just it's situational, right? So when she's exercising, it's provoking the wheezing, cough, shortness of breath. And this has been going on for a month. So I'm already like ruling out it's probably not infectious. Okay, probably something more like asthma. But I keep reading. She has an albuterol inhaler. Okay, so she's been previously diagnosed with that. She does take oral contraceptives, which I take note of because it can be it can be a problem like with a pulmonary embolism, but so far it looks more asthma-y than PEE for me. And then looking at her vital signs, they look pretty normal. And she's not in any distress. Let's see. She has, okay, what are they trying to describe here? Thickened plaques on the skin with excoriations. No, not psoriasis. Although sometimes they can be described similarly, plaques. I agree with that. But no, they're trying to point you in the atopic term. Yes, atopic term. So like eczema, right? And especially the location. Antecubital fossa are going to be in the elbow creases. Okay, that's eczema. And we already know that there's atopy related to asthma. So this is kind of just helping you confirm what you think it already is. Okay. Read the chest x-ray, wheezing greater in the expiratory phase, which is again more classic with an obstructive process like asthma. And what is the most appropriate test for the patient? So they're not in any acute distress. They're in a clinic, not in an emergency room. Let's see. So what did y'all put for this one? From the little bit of results that I got from our test, the answers were between chest x-ray and pulmonary function testing. Now let me explain. I think it's PFTs, and that's because this patient is not in any acute distress. They don't have any let me take a step back. You do not need a chest x-ray to diagnose asthma. Okay. Chest x-rays, when we get chest x-rays for asthma, it's because maybe we hear some rhonchi somewhere or they have an infection, and we're looking for like an infectious provoking part for the asthma. But asthma in and of itself does not require a chest x-ray for diagnosis, especially not in the outpatient setting when we know she already has asthma and she's not having any asthma symptoms at the moment. So in this case, the best thing would be to do pulmonary function testing to confirm the asthma. Okay. So again, another PD, 5-month-old. She's brought in for runny nose, fever, decreased appetite, increased work of breathing. So does that look familiar to another one that we saw before? They're mentioning that they're not eating as much. They have a decreased work of breathing, runny nose, fever. Yes, right. It looks similar to a previous case that we already saw. And then we keep going. They have expiratory wheezing, similar to asthma, but it's an infectious cause, right? An infectious cause of inflammation in the lower airways. And then the x-ray doesn't really show much. X-ray is pretty normal. And so what do you think? Even if you didn't have the x-ray, what would you think it is? Bronchiolitis. Very good. Do you see how the vignettes are pretty similar from one case to the next for all the bronchiolitis ones are going to look más o menos similar to like what we've seen here. And that's kind of the point I wanted to make is like once you do enough questions, you'll start to pick up on the same types of descriptions in questions. All right, so now we have a 2-year-old coming into the ED with a 3-day history of URI. And now they're having increased respiratory distress for the past 12 hours. Started with rhinorrhea, had a mild cough, and the cough is worsened, now has a barking quality. I mean, if you just had to highlight one word here, the barking kind of gives it away, right? Good. Let's continue. Breathing has become audible, so maybe some stridor related to it. They have a low-grade temp. Let's see. Oxygen saturation it's not horrible. It's not normal either. And they have, okay, here we go. Stridor at rest, present, and barking cough. So what do we think as far as the treatment of choice? So we have to know what the treatment is. Well, first of all, what is this? Group. Well, it's too easy to ask you if it's croup. You saw the barking and that was it. That's all you needed to know, right? But it's not asking you what it is. It's asking you how would you manage it. And so this patient, would you say they're like mild, like no biggie, just go turn on your humidifier at home? No, right? They have stridor. They're having increased distress. That's why they're here in the ER. If you just say, you know what, just go get some humidifier, you'll be fine. Like, that's not going to help the situation. We need to treat them. And so there's really two treatments that we recommend for croup. They are racemic epinebs and IM or PO dexamethasone, which is a steroid. It's that specific steroid, dexamethasone. Okay. And so in this case, when we read it, the only one that we just mentioned is nebulized epinephrine. Okay. If this answer E instead had been oral dexamethasone, both of them would have been correct. But we do not give hydrocortisone for croup. Does that make sense? Do you see why it's not humidified oxygen? First of all, humidified oxygen, the patient's not hypoxic enough really to need oxygen. But they are bad enough to need a neb to kind of reduce the inflammation. Got it? All right, so next up we have 3-year-old. Seen in the ER. They were previously seen ER diagnosed with bacterial pneumonia. All right. All right, they didn't need to be admitted, so we're talking about outpatient management in pediatric asthma. Pediatric asthma is a little different than adult asthma. This is a really hard question. I would not get this specific on the test. The reason why I put this question on here was because I wanted to use it as a teaching point for you now. So the treatment of choice for asthma in outpatient would be amoxicillin. And it's not the low dose. This low dose is a pretty small dose. We want to do a high dose amoxicillin. It's like the same dose we would give for like an ear infection or otitis media. So I like I said, I wouldn't ask you that on a test. I think it's a little bit too specific, more farmy. But high dose amoxicillin is a treatment of choice for outpatient management of pediatric pneumonia. If it was an adult, would it be azithro? I'm not saying anything about asthma. Did I say asthma? Oh, I meant pneumonia. Sorry. Okay, that's why. I meant pneumonia, outpatient pneumonia. Pneumonia. Thank you. My bad. I don't know where I got asthma from. If it was an adult, you could do, I would probably do azithro. I think you can do a beta-lactam, but I don't usually see them start on beta-lactams. So azithro, I think doxy is on there too. And then if they were sick, comorbidities and stuff, then a fluoroquinolone. Okay. 65-year-old coughing, weeks of coughing, so not that acute, few weeks. Sometimes bloody and associated with chest discomfort, okay, when he coughs. Smoking for the past 40 years, also has COPD and hypertension. Takes metoprolol, Advair, albuterol. Okay, let's see. Look at his vital signs. Good. Decreased breath sounds in the right upper lobe. Right upper lobe mass. Is this person high risk or low risk for cancer? Okay, yes, you should have said high risk for cancer. They're a smoker, 40 years of smoking. So that is high risk for cancer. We have a mass. It doesn't tell us a whole lot about the mass, but the really key part of the stem of this question is confirm, okay? The best confirmatory test is what it's asking. What will give us the best chance of confirming what the diagnosis is? And in this case, it would be the biopsy. Does that make sense? If it had said, like, instead of the best confirmatory test, if it said like what the next step would be, I would probably have chosen the CT. Does that make sense? Yeah, surprisingly makes sense. Okay, I hope things should start making sense. I mean, as you start progressing through the module, you kind of gain the book knowledge, and then you have to take it and like be able to apply it. Okay, and I think what you should be doing as you're learning is periodically doing these questions. It really, really helps to dissect questions, because when you go through these, you're picking out those key factors, and it helps you distinguish between all the many things that cause the cough, that cause the dyspnea, that cause the hemoptysis. Okay, so this one, they're telling you right off the bat there's a college student. If I had to guess and I didn't have any other information, I'm going to go with mycoplasma. Okay, now we're not going to do that because that's not a smart way to take a test. But as I'm reading, I'm already making my working diagnosis: walking pneumonia, mycoplasma pneumonia. And so unless the rest of the stuff in this vignette convinces me otherwise, I'm going to pick the answer that correlates with what I think. So I'm reading. They have a dry cough, weakness, headaches. So kind of more of a like a atypical type picture. Low grade fever, vital signs normal, crackles, kind of non-specific in the lung base, some anemia, and then remember I told you earlier today, cold agglutinins, that confirms it. So what is the organism most likely in this case? We said mycoplasma. If instead it asked me what would the treatment be first line, what would you say? Azithromycin. Very good. Macrolide. Very good. Very good. Yes, both right. All right, 65-year-old seen in the ED for persistent cough and fatigue. Okay, that doesn't really help us out much. That could be a ton of different things. And it's been persistent. Illness began 2 weeks ago as a cold, but now the cough's gotten more severe. Remember, Dr. Hidalgo said that a lot of times, like a viral thing can make our defenses weak and then lead to a bacterial thing. So anyways, keep reading. Cough has gotten worse. No fevers, no colds. Cold symptoms resolved. Temperature is a little bit elevated, but not abnormal. Blood pressure is blah, blah, blah. Oxygen saturation is in lower limit of normal. Rails are located in the right lower lung field. Very specific there. They're in the right lower lung field. Okay, otherwise normal. So which of the following is the indication for, out of all the stuff we saw in the vignette, which is the most important finding that tells us that we need to get a chest x-ray? The most important. There are several things in here that make me want to get a chest x-ray. Yes, exactly. So when we're hearing something that focal, just in the right lower lung field, it makes me think lobar consolidation. And so if I just had a patient, any patient that came in with a cough and a 90 heart rate of 90, which is technically normal, that doesn't make me want to get a chest x-ray. Respiration of 20, well, that's just barely above normal. So no. Oxygen saturation of 95, that's the kind of lower limit of normal. So no. And age of 65 is the only one that kind of made me think a little bit, because I probably would want to, but that is not as good of a reason as it is the right rails in the right lower. Does that make sense? It's a focal finding. Focal finding makes me think I need to go see if there's a consolidation there. All right, next up, another PD, 8-year-old girl, productive cough. It's been over a week, fever for the last 3 days. So something's changed in the last 3 days that makes us think that whatever she had for the over a week has now changed a little bit. Now 3 days of fever. Vital signs of the low grade 101. Heart rate's a little up for an 8-year-old, maybe not terribly high. Blood pressure is good. Respiratory rate, it's a little bit up, but not terribly bad. Oxygen saturation is low though, and that's on room air. So that's low. Breath sounds decreased at the left base. Okay, another focal finding, right? Left base, one area. X-ray shows, again, a left lower lobe consolidation. So it confirms what we heard on exam. What is the most likely cause? So what do we need to pick up? They didn't just say this on accident, that she had this cough for over a week, and then she got a little better with the cold stuff, but now for the last 3 days, she's had this fever and this focal finding. So this is a classic example of had a viral and it progressed over to a bacterial. And if I was guessing, it might be the flu, but it might not be. I'm not sure. But either way, for this one, that's what it's asking us to pick up. And the only thing with this is if it were the flu, we might think staph. But in this case, because we think of most common bacterial infection, a consolidated infection is going to be strep pneumo. Most common. So post-viral can be Staph aureus. Usually Staph aureus is not quite as lobarly consolidated. When they say lobar consolidation, they're usually talking about strep pneumo. I think that one was a little tricky. All right, 65-year-old coming to the ED. Was it staph in this one? Maybe. Let me see. It doesn't really say how it is more scattered in an area of the lung. It could be, if they had said specifically they tested positive for influenza, then I would pick Staph aureus. Or like a lot of times they'll say, oh, they were on a course of oseltamivir for the flu. And then they come back and they have this higher fever, increased cough, productive, and they have a consolidations on the chest x-ray. I would say more staph. That one was a little hard though. So this one's 65, pleuritic chest pain, productive cough, mild shortness of breath, cough, productive cough, dizzy and drowsy. So that's not good. An older person with dizziness and drowsiness, they have a pretty high, that's a high fever for a 65-year-old. Old people don't mount the same immune response that young people do. So when you see a fever of 102 in an elderly person, that's no joke. This is also low blood pressure, high heart rate. I'm thinking maybe this patient could be septic. And then look at their oxygen saturation. That's super low, 84. They need something like now, okay? Let's see, breath sounds decrease over the left lower lung field. Chest x-ray shows a left lower lobe infiltrate. So they have pneumonia, but they don't just have pneumonia, they have respiratory distress. Okay, probably sepsis with these vital signs. And so what are the major factors in resuscitating a patient when they're in distress? Do you know? It's as easy as A, B, C. Good job. So A, B, C's. A is what? Airway. Very good. So in a patient like this who's in distress that has cough, shortness of breath, we know they have pneumonia. They told us they have pneumonia. And yes, 100% they need IV antibiotics. But if they can't breathe enough to administer the antibiotics, like they're going to die before the antibiotics start to take effect. So we always tackle the airway first. And so in this case, what would be the correct answer? Well, first of all, they're super hypoxic. So we need to supplement their oxygen. And then we need to do an airway assessment. Do they need to be intubated, in other words? BiPAP is a possibility. Like we can start BiPAP, but at the rate this patient is going, they're probably going to have to be intubated. We do saline boluses for sepsis as well, and we do IV antibiotics, and they probably need an EKG. I don't know about the aspirin, but something to bring down the fever. So all of them are correct. Which is the best next step? They love to ask questions like this. So that is the correct airway first, airway, breathing, circulation. It's a hard question. Those are hard. So we're not saying they need to be intubated here just yet. We probably need to get an ABG as well, but we need to assess their airway, like see if we need to intubate. We can start them on some oxygen, see what their work of breathing. Their work of breathing is a little high. Depends how long they've been this way. We need to bring their fever down. We have a source of the infection. We need to start a bunch of stuff. But the airway assessment is basically saying, like, do they need to be intubated or not? There are certain criteria. I think most ER providers just kind of know when we get to the acute respiratory distress and ARDS lecture, you have a little bit better idea of when they need to be intubated. But basically, anyone that you expect are going to tire out from the rate that they're breathing or the effort they're having to put in, someone that can protect their airway needs to be intubated. So there's not, I haven't covered the exact. Yes, sometimes yes. So just like you mentioned, depending on their glass glaucoma scale, you might have to intubate. That's separate from this. This is for the specific respiratory distress, but I don't think you should have to decide when you have to do that. But for this step, that would be the correct answer. BiPAP, you might start them. Sometimes you can start on BiPAP. Sometimes you can start with that and see if they oxygenate better and then stay there. And if they don't, then you can step them up to intubation. What's the B? Oh, what's the B and A, B, C's? Oh, so airway, breathing, circulation. Breathing is like actually ventilating for the patient. I always get airway and breathing kind of lumped together, but airway, breathing are the number ones, and C is circulation. 47-year-old, 33 pack history. He's trying to stop smoking, reduced to 5 cigarettes each day. That's good. Little bits at a time. Sometimes are better than nothing at all. Let's see. Early COPD. And as hypertension, controlled, keep reading, hypertension, coronary artery disease, talking about all sorts of stuff, just trying to distract you, basically. Vital signs are normal, physical exam unremarkable, has some bilateral scattal wheezes. Now he wants to know about screening. He's concerned, okay? So according to the USPSTF, which of the following statements is correct? Now, we don't usually do the which of the following statements is correct questions on our tests, but sometimes it's the best way to know if you really know something, okay? So first of all, we have to know the screening guidelines, okay? We have to know which qualifies someone for screening. Okay. And what's the age range for screening? 50 to 80. 50 to 80. Good. 50 to 80. Just based on the age alone, are there exceptions for the age? Are there like a if this, then this for age? Or is it a hard fast 50 to 80? On the chart, does it change the age range? Okay, I'll give you that. Okay, to stop screening, yes, but to start screening, like for instance, let me make an example out of this. So for colon cancer, we start screening for a normal average risk person at 45 years old. Okay, regardless of your history or whatever. If you are 45 and up and you have no comorbidities and no increased risk, you're starting at 45. But there are exceptions. So like if you have a first degree family member with a history of cancer, you change when you start for those patients. You change it to 10 years earlier than when they were diagnosed or 40, whichever is earlier. Okay. So in the USPSTF recommendations for screening for lung cancer, did they have a caveat that said we can start earlier if they have this risk or whatever? No, right? It's 50 to 80. Okay. So in this case, he's 47. He's close. We're going to have to keep a real close eye on him, but he's not there yet. He is not 50 years old yet. So in this case, we do not screen him. He is not a candidate for screening yet. I know that's tough. They put all this stuff in here to make you think, yeah, I think we need to screen him. He's got a history of cancer in the family. He's got all this other comorbidity stuff. Like, I'm worried about him. I think we need to screen him sooner. No, we wait till 50. Textbook. Maybe. I don't think the insurance will cover it. And CTs are pretty expensive. But we have to also show here that he's not, it's not a diagnostic thing, it's a screening thing. If it were a diagnostic thing, like let's say his having significant limitation, like it's jumped up recently, right? Like he was able to do some stuff, but now it's like he can't even walk to the mailbox. That would be a diagnostic evaluation. So we wouldn't be like, oh wait, hold on, we need to wait 3 more years before we investigate that. Okay, this is just talking about screening. Okay, does that make sense? All right. All right, another screening one, just to kind of give us some variety here. Okay, so this one is 60 years old. He has a 40-pack year history, but he quit smoking 18 years ago. This is very important. If I stopped right there and it's asking me which of the following statements is correct, what do y'all think? All this other stuff in here is just trying to confuse you. The question is asking which of the following statements is correct. All right, some of y'all said C, some of y'all said D. All right, it's tricky. That's why I wanted to talk about it. Okay, so the USPSTF recommends that anyone between the ages of 50 and 80 with greater than a 20-pack year history of smoking that have not quit in greater than 15 years. So if they quit within 15 years, that's who would be screened. Or if you have a reason why you would be dying from something else, or if you reach the age of 80. Okay, so in this case, he meets criteria for his age, he meets criteria for his smoking history, but he rules out because he's quit greater than 15 years ago. So in this case, the patient does not require screening because he's at lower risk and may incur potential harm from testing. So how do we screen? We use CTs to screen, and CTs emit quite a bit of radiation. So we don't want to just use a CT and screen from a textbook standpoint just because. Okay, we're talking about hard, fast recommendation guidelines. This is test world. Okay, so maybe there's some leeway in the real world, but from a testing standpoint, you have to stick to the recommendations. Does that make sense? Okay. Like I said, these are a little bit harder, probably harder than what I would give you on my test, at least some of them. And that's because I want to talk about it. Okay. Next up. Oh, doing great, by the way. It's hard to sit there and listen for this. It's hard to talk this long. All right. So 20-year-old emergency department, worsening cough, rapidly worsening cough. Illness began 2 weeks ago. Rhinorrhea, followed by a mild cough, low-grade fevers. She had uncontrollable paroxysms of coughing, followed by gasping inspirations. What is that describing? Whooping cough. Very good. Bordetella pertussis. Okay. She has some post-tussive emesis. All right. Vital signs. She has a low-grade temp. She has some injection. Breath sounds are clear. 2 coughing episodes. She sent culture and PCR to give the suspected diagnosis, which we know. Which of the following is the appropriate treatment? Good. The treatment for whooping cough is azithromycin. They're pretty specific CDC guidelines from when to treat. If you're within the first 2 weeks or so of the infection, the sooner the better for treatment. Otherwise, they can clear on their own the infections, but in this case, I would pick azithromycin. Now, if it's been more than a few weeks, if they're a young person or really old person or they have comorbidities, then you always want to treat. Yes, where is that? I don't know where it said unvaccinated, but if it said that in there, yes, for sure. Unvaccinated sibling. There we go. You didn't really need it because the paroxysmal coughing tells you it's pertussis. But yeah. 6-year-old, febrile illness, slightly productive cough and rhonchi. Her influenza test is positive. Influenza test is positive. Okay. She's sent home with oseltamivir and supportive measures. Okay. 2 days later, she's brought to the ER. Tachypnea, her course changed. Tachypnea and oxygen saturation that's low. She doesn't want to eat anymore. She's admitted to the ICU and started on azithromycin. On day 2 of the hospitalization, her respiratory status deteriorates, requires high flow oxygen, and chest X-ray shows consolidation with a small effusion. So this picture is pointing you in which direction? Right? So what do you think happened here? She had the flu. That's 100%. She was treated for the flu. She developed a pneumonia. Okay. Yes, but there's more to it than just viral to bacterial. So she was seen in the ED and admitted, but she was started on azithromycin. Does azithromycin cover staph? No, it doesn't. Azithromycin does not cover staph. So that's why she got worse. She deteriorated. We didn't start her on the appropriate antibiotic. Okay. So this is a case where it's trying to really point you in the direction of Staph aureus. Does that make sense? All right. 19-year-old. Okay. Male basketball player. They are not just telling you he likes to play basketball for any specific reason. For any just whatever reason. They're telling you because they want you to know that he is 6'11" and he's thin and tall, right? There's only one thing I think of in our module that's saying thin and tall, and that's spontaneous pneumothorax. Okay. If you keep reading, it makes sense. Dyspnea, chest pain, no specific trauma. He hasn't been in any risk factors for like long car rides or plane trips for PE. Yeah, he's the blah blah blah. He's long, tall, skinny. Except for the dad in Hotel Transylvania is a little older than what I would want. But yes, tall, skinny with blebs. Very good. So he has spontaneous pneumothorax. And it says here, does not have detectable breath sounds in the left lower lip. Sometimes they give you like overkill of information in a vignette. Like you didn't need all that, but it all just helps you be confident that you're picking the right answer. Good. 3-year-old. We're almost done. 3-year-old boy. ED by the father. Fever, increased difficulty breathing over the past 5 hours. So fever, increased breathing, difficulty breathing. Father states no one at home is ill. Several kids at daycare have been sick. Immunizations are not up to date. That is super key here, okay? Temp is pretty high. Ill appearing. They don't just mention that for any reason. Kids, if they mention ill appearing, they have distress, leaning forward, tripoding, okay? And he has stridor. He's drooling, and he speaks with a hot potato voice. It's another way of saying it. Does this point you in a certain direction when you read this? Right. If it's not clear to you that this is epiglottitis, you need to go back and review the pulm infections because this is very classic epiglottitis. And so my question here, these are all from standardized sources, so I didn't make these questions up. This is how they normally do that. It says, what study may help confirm? Now, remember, you don't have to get this. In fact, I would probably advise against it, but this is a textbook and it's asking you 2 questions in one. It's asking you, can you recognize that it's epiglottitis? And do you know what exam you can do to get the thumbprint sign? This is essentially what it's asking you. So what's the correct answer in this case? It's not a chest x-ray. So it's a lateral, yes, muffled voice is hot potato voice. Lateral x-ray looking like this to see the epiglottis, and you'll see the thumbprint sign. It's the soft tissue lateral neck x-ray. However, I'm telling you this with a caveat. I probably wouldn't send a 3-year-old to get an x-ray because chances are they're going to freak out. AP is a straight on view. It's not going to show you the epiglottis. It's just AP from anterior to posterior. You need to see the lateral. You need to see it from the side to see the thumbprint sign. Yeah. Good. 48-year-old alcoholic male. Again, they're not just telling you that just because, like, let's get the cheese man on this patient. No, they want you to know he's alcoholic. And I could not read half of the rest of this other than current jelly, and I would already know that it is Klebsiella. They usually make Klebsiella vignettes this simple. This is a real vignette from a real testing source. So that's all I gotta know. Okay. Sometimes these alcoholics, they can aspirate because they get drunk, and then they like either laying down on the pass out on the bed, or they're laying in the chair, and they aspirate their own secretions, and this can cause like lung abscesses and infection, depending on, usually the right side is more common for an aspiration pneumonia. If they are upright when it happens, usually right lower lung tends to be involved. If they're laying flat, usually right upper lobe tends to be involved, and it tends to be like a mixture of flora, not just Klebsiella, but it can be other things like anaerobics and things like that that form these little cavitations. So look for aspiration, look for alcoholics, and look for Klebsiella. Look for lung abscesses as well. It can cause those too. Okay. 19-year-old college male, another college student. All right. We already saw one that was similar to this. Vague discomfort, mild shortness of breath, sitting in dorm room when his symptoms started. Okay, wait, this is getting a little different. Okay, now they're telling you he's 6'5" and 180 pounds. So the college student wasn't that helpful in this case, right? It's more telling you like his age. So keep going. They gave you very specific height and weight. So now I've changed my thought from mycoplasma to probably pneumothorax, right? So using ultrasound, they confirm the diagnosis. It was a symptom abruptly started. He was just studying. A lot of times it's when they're like smoking weed that this happens, actually. So following which of the following physical exam is the most common physical exam finding in this? This is actually a really hard question. Okay, this is a really hard question, and I only shared it with you because I got it wrong and I wanted y'all to get it right. So all of them are true. So decreased breath sounds, yes, you can have decreased breath sounds. Hyperresonance supercussion, yes, you can have hyperresonance supercussion. Inferior displacement, well, depending on if there's increase in the airspace there, you can, but that one I wouldn't have chosen. Tracheal deviation, he does not sound like he's having a tension pneumothorax, so I would cross that one out. The only choice left, so between A, B, and D, the actual correct answer is D. And I'm showing you this because I got it wrong. Okay. I know. Yes, I know. Okay. It's asking you not what would be present. These are present. Decreased breath sounds is present. Hyperresonance percussion is present. But it's asking you the most common physical exam finding. I got it wrong too, y'all. I'm sharing the knowledge because now I'll never get it wrong again. Okay. The most common physical exam finding in a spontaneous pneumothorax is sinus tachycardia, believe it or not. Okay. If he's doing pretty well, the thing about it is the more pneumothorax you have, the bigger the pneumothorax is, the more decreased breath sounds that you have, and the more hyperresonance supercussion that you have. If you have a really small pneumothorax, less than 15%, you're not really going to have all of those really obvious physical exam manifestations, but you will always have sinus tachycardia, or almost always. Does that make sense? I was stumped too, so we're all in the same boat here. But I learned really well when I get things wrong because I'm like, heck, if anyone's ever going to trick me twice. Okay. So I'm sorry. That was kind of a low blow. And if you got that wrong, I would not have counted it wrong. Like I would have said, no problem. You're right. I don't want you to think that these are not correct. I just want you to know I got it wrong. So I want to share it with you. Okay. All right. This one is pretty straight recall. So pleural fluid analysis with exudative pleural effusion. So exudative is going to have what? A lot of what? Protein. Very good. Protein. Does it have a lot of triglycerides? No. Triglycerides are seen more in chylothorax. Let's see. Is the pleural ADH to serum ratio low? No, it's high, right? We have more LDH. Okay. Does the pH affected really? No. Does the glucose go up if we have exudative? No, we have things in there that can kind of eat away at the glucose. And so it can be lower in most cases. So the only one that makes sense is the pleural protein greater than 0.5. So it's Leitz criteria is another way of asking it. Okay. All right. This one's kind of hard because it's hard to see the x-ray, but 19-year-old male, chest discomfort, 19-year-old male, chest discomfort. We've seen several 19-year-olds. So started this morning. Nothing happened. It just kind of started all out of the blue. He doesn't have any cough or congestion. He has a mildly diminished breath sounds on the right and probably tachycardic. Okay. He's breathing comfortably. He's tall and thin. And you saw a mild apical pneumothorax. And it's about 10 to 15% of the lung field. So it's actually up here. It's kind of hard to see. But either way, what is the most appropriate treatment? So we haven't really covered this in class, but I did mention it in my Panopto that if you have a young, healthy person with a very small pneumothorax that's oxygenating well, that's not having work of breathing, that actually looks pretty good, and it's less than about 15%, you can actually give them 100% O2 and follow up with serial chest x-rays. You don't have to put a chest tube in every single patient with a very mild pneumothorax. Okay. (26) 2-year-old child, ED, several hours of loud breathing. I don't know what that means. We're going to have to keep going, okay? I don't know what they mean by that. But the next sentence tells me barking cough. So I'm thinking the loud breathing is related to stridor. Yes, it can get bigger. That's why we do the serial chest x-rays. If at any point we see that the patient's starting to have increased work of breathing, struggling, dropping oxygen saturations, anything like that, we repeat the chest x-ray. And if it's increased in size, then we can put the chest tube in. Most of them heal up on their own, no problem. Like the really small ones. Okay. Oh, no. You're going to get follow-up. It should probably say serial chest x-ray. So you're going to get an x-ray at least 4 to 6 hours later, and then you're going to keep them in the house, and you probably get another one a few hours later. You're going to check it several times throughout the next 24 to 48 hours to make sure that it's not increasing in size. Okay. Barking cough. So if I just keep going through all this, it's telling me that the kid has a barking cough, that he already has stridor, mild respiratory distress, and stridor, which he already said, and lots of coughing. So what about, we already talked about the management once. We said if the answer choice was there, racemic epi, we gave it. In this case, it's not giving us racemic epi. The only one on here that makes sense if we know what we have in the vignette, because it didn't tell us the kid has croup. It described it for us and we figured it out. And so in that case, the correct answer would be dexamethasone. Nice job. One more, last one. Okay. 10-year-old male, shortness of breath after playing outside in the snow. So cold weather and also activity. History of asthma. So that's kind of what I was thinking anyway. Used inhaler twice prior to the arrival with hours later. So he's already had albuterol a couple times. Otherwise, wheezes bilaterally, mildly uncomfortable. His oxygen saturation is a little low. After bronchodilator treatment, he's still mildly wheezy, but important. So we gave him more bronchodilators probably. What is the next best treatment? So this is an acute asthma exacerbation, right? This is an exacerbation of asthma. Okay. Good. So what are the two major treatments in acute asthma exacerbations? The first one that we always start with is inhaled beta agonists. Okay. And then in addition to that, either concomitantly or after we see how they're improving or not improving, we add steroids, and they're usually oral, IV, or PO, not inhaled. Okay. How do we do? It was hard, right? Did it help going through it and like talking through and like dissecting? I think it helps. Good. Okay. So what I'll do is I'll have to download the test with the explanations and the correct answers, and I will post the results of that. How similar would you say? No, my exam's probably a little easier than this actually. Some of the questions were right on, like some of the PD and infectious the infectious ones were pretty straightforward, pretty right on. But like the weird, like screening, like being really specific and like all that, or like the first few that were more cancer, like what the next best step is with like that's versus this, that's a little too specific. But like the regular ones, the ones, you know, the what do you call it, the infectious space ones, I think those are pretty right on. So it's a mix. All of my questions for the most part are vignette style. I'll usually have like maybe one that's straight recall and everything else is vignette style. But if you get good at picking the important stuff out of vignettes, it should not be that bad.